Good afternoon. My name is Adrian Dix. I'm BC's Minister of Health. To my right is Dr. Bonnie Henry, BC's Provincial Health Officer. It's our COVID-19 briefing for Thursday, January the 14th. We're honored to be here on the territories of the Lekwungen-speaking people, of the Sungis, and the Esquimalt First Nations. You'll note, and I think it's just been posted or being posted, our weekly report on outbreaks in long-term care, assisted living, and independent living sites should be posted at the BC CDC website. Tomorrow, Friday, there'll be a written briefing posted approximately 3 o'clock, and we're going to be aiming for that tomorrow at 3 o'clock. And then on Monday, we'll be again briefing from the Press Theatre here in Victoria, Dr. Henry and myself. And with that, it's my honor to introduce Dr. Bonnie Henry.
Thank you and good afternoon. Today we have 536 new cases diagnosed with COVID-19 in British Columbia, 6 of whom are epidemiologically linked cases, bringing our total number of people diagnosed with COVID-19 to 59,608. Of the new cases, 102 are people in the Vancouver Coastal Health Region, 253 are in the Fraser Health Region, 21 people are on the Vancouver Island Health Region, 115 people are in the Interior Health Region, and 45 are in the Northern Health Region. We now have 4,624 active cases, of whom 362 people are in hospital, 74 in critical care or ICU. Additionally, there's about 7,303 people under active public health monitoring, and 52,605 people have recovered from COVID-19. In the last day, we've had an additional 7 people in British Columbia who've died from COVID-19, bringing that total to 1,038 people in BC. As always, we think of those families, the caregivers, care providers, and the communities that mourn the loss of 7 more of our seniors and elders. Our thoughts and our prayers are with you. We have 2 new healthcare outbreaks at Brocklehurst Gemstone Care Centre and Maple Ridge Seniors Village, and 2 are now declared over. The Suwatal Lalem outbreak here on Vancouver Island, and the Veterans Memorial Lodge as well. That leaves us with 52 active outbreaks in long-term care and assisted living and 12 in acute care units, involving 1,454 residents of long-term care and 776 staff now with active cases. Since the start of our immunization program, up until yesterday, we've immunized 69,746 people in every health region and some very remote communities across British Columbia. Right now, our focus, as we know, is on those who are at highest risk. And we are tracking and reporting on this daily, and we are building a dashboard that will make this more available in some detail for you as early as next week. As our supply increases and immunization programs expand to more and more people in the province, this process will become more complex and more challenging for all of us. And I'm very pleased that Dr. Penny Ballum, as we mentioned yesterday, has joined our BC immunization team as the executive lead to support the scaling up of efforts that we are going to need. I know many people are also wondering about when they will show up in the vaccine access column, and we have put out some details about Q1, so between now and the end of March, the people most at risk and people who are supporting our healthcare system are the priority, and we are working on giving details about everybody else, starting when we expect to see additional vaccines starting in April. And we will be providing details of that next week, so please be patient. We have a lot of considerations that need to go into this. We're still working on the issues of how much vaccine we expect to receive when, but we will be having more details provided in the coming days. Also want to talk today about the new variants that we have seen here in British Columbia. As you know, there are a number of COVID-19 variants that have arisen around the world that have caused increased concern, and we are paying close attention. We have been screening, both doing random samples of some of the isolates that have arisen, and screening as well on people who have traveled. And we now have 4 confirmed cases of the UK variant in British Columbia, 3 of whom are linked to one specific traveller, and 1 related to an additional traveller. There are no other contacts, and we don't believe that this has spread at all from these 4 cases. In addition, in the last day or so, we've also identified our first case of the South African variant of the COVID-19 virus, and this is in a person who has not known to have traveled or to have connection with a traveler. So we are still investigating where this person might have contracted this virus, and that will continue. It is, of course, concerning that we don't know where this arose. However, at the moment, it does not appear to have spread in the community beyond the person that we've identified. Both of these new cases, the 4th UK variant and the South African variant, were identified in people who live in the Vancouver Coastal Health region. As you know, we do have concerns that some of these variants, particularly in the UK, may allow the virus to spread more easily. And that is why it is important for us to continue to monitor and to do the whole genome sequencing that we've been doing in terms of surveillance for these variants. It's also why it is so important for all of us to continue to take those measures to prevent the spread of COVID-19. That means not gathering. It means keeping your contacts small, making sure you're using your protections, following and closely monitoring your personal health, and if you have any symptoms at all of concern, to make sure that you get tested. I have spoken many times before about how we are in different boats, how our experiences are unique through this pandemic, even if we are all in the same storm. Here in British Columbia and around the world, we have far more in common than what separates us when it comes to COVID-19. We are all susceptible to getting ill from this virus, and we all have a choice about our daily activities and how we treat those around us. COVID-19 doesn't discriminate, but systems do. And it has illuminated for us many long-standing inequities in different parts of our society. It has also highlighted how First Nations, Métis, and Inuit peoples in British Columbia did not come into this pandemic on equal footing. Recently, I have been very saddened and disturbed to hear reports of discrimination and racism that is counter to the kindness and compassion that we expect and have seen in British Columbia from so many people. In particular, members of the Cowichan tribes here on Vancouver Island have been stigmatized and discriminated against as a result of COVID-19. I'm pleased to receive reports that the tribes themselves, First Nations Health Authority, the local island health public health teams, as well as many others, have responded quickly and collaboratively to support those who have COVID-19 and who are self-isolating and caring for each other. This type of racism cannot be tolerated, and I stand against this with my colleagues to say this must stop on Vancouver Island and elsewhere. Racism has no place in our society, in our communities here in British Columbia, and we must all take the time to speak up and speak out. The health challenges that come with this virus are difficult enough without also having to face stigma and discrimination from those around us. We must go beyond good intention, and each of us find opportunities to take anti-racist actions. The Northern Health Indigenous Health page and National Collaborating Centre for Indigenous Health have developed a short animated video that I encourage all of us to watch. This video, called Healing in Pandemic Times, speaks to the challenges that Indigenous peoples face and have faced, and the role we all play in helping to address those challenges. It's available on the website of Northern Health, and as also will be available on the BC CDC website, and we'll send out a link to that as well. Please take a few minutes to look at this today. This is one step that each of us can take today towards ending racism and having an inclusive, supportive community that we all want and all need. During this pandemic, our strength as a province has been all of us working together to a common purpose, to do all we can do to keep our loved ones, our communities, and ourselves safe. COVID-19 requires that while we stay apart, we must find ways to safely connect and promote a spirit of unity, compassion, and support. Using your layers of protection helps stop the spread of COVID-19, and your individual efforts and actions can help to stop racism and discrimination. That also needs to start today. COVID-19 is our shared challenge, and one we will only get through by supporting each other. We face these new challenges every day, but there is an end in sight now. No matter where we are in the province, choose unity over division. Take a few minutes to learn about healing in pandemic times. And as always, remember, we will get through this by being kind, being calm, and being safe.
Thank you very much, Dr. Henry, and I wanted to start by expressing my condolences, that of the government, I think that of everybody in BC, to the families, the friends, the caregivers, the communities of the 7 people who passed away from COVID-19 in the last day, 6 of whom lived in Fraser Health and 1 on Vancouver Island. This is, I think, an extraordinary and difficult time to be dealing with the issues of grief, especially in some of those cases which occurred in long-term care homes in the Fraser Health Authority. And we are with those families and thinking of them today, and our hearts go out to all of them. I wanted to note that in our healthcare system today, in terms of our bed capacity on the acute care side, we are at 89.9% of base beds and 71.1% of overall beds filled. Typically this time of year, it should be understood that that number is 100% of base beds. So we are continue to be in good shape in terms of beds, although the stress in parts of our acute care system is very much there, and you can tell that by speaking, as I do regularly, to people working in the system. In critical care, 77.8% of our critical care beds are currently full. Those are the base beds, and 54.2% of the overall beds. We have, as Dr. Henry has said, 4,624 active cases of COVID-19, and we continue to be concerned, as Dr. Henry has said, with the situation in Interior Health in particular today, and in Northern Health, where at least since the Christmas period we've seen an increase in the number of cases, and we continue to be concerned in it and remind people everywhere in the province of the need to dig in right now and to follow public health orders and to express our solidarity and support for everyone working in healthcare in all regions of the province, but in Northern Health and Interior Health as well, where they have not seen it, sometimes in the pandemic as many cases, but they're certainly seeing their share now. As 69,746 doses of vaccine delivered, as you will have guessed. New vaccine has arrived. Since we spoke yesterday, approximately 25,000 doses of the Pfizer vaccine. We're expecting more Moderna vaccine before the end of the week, and that allows us to continue across health authorities to pursue clinics everywhere. And our focus continues to be on long-term care workers, on long-term care residents, on assisted living workers, on assisted living residents, and other people working in acute care, and other vulnerable groups, and in particular, rural and remote Indigenous communities. I want to report today on progress on our surgical renewal commitment. I'd note that since we resumed non-urgent surgeries on May 18th, the health authorities have completed a combined total of 214,858 surgeries as of January 10th, 2021, of which 167,381 were urgent and non-urgent scheduled surgeries, and 47,477 were unscheduled or emergency surgeries. We reported in detail on this with Michael Marchbank, who's directing the surgical renewal commitment for the province last week, and I encourage you to go on the Ministry of Health website and review those reports. In addition, I'm happy to report that in the period over the Christmas period, from December 21st to January 3rd, we've updated numbers that the total number of surgeries completed was 6,078 in that period. That's from December 21st to January 3rd, and that is 595 more surgeries than the same two-week period last year. That is an achievement by our healthcare teams. Briefly, to bring you up to date on the contact tracing recruitment initiative, an additional 13 roles were filled this week. That's 1,326 individuals hired, which is obviously more than the 500 initially announced in August by the Premier. We also have 369 candidates in the interview stage and 124 candidates in the offer stage. As there are significant candidates in the pipeline, discussions are underway around whether these will be accessed for continued contact tracing work, or if there are other opportunities to access these candidates, or there are opportunities to access these candidates for other roles. I want to thank everyone doing this work, and the addition to our existing teams of 1,326 people shows our commitment to that work. I think the Premier talked today about our health human resources initiatives to support senior services in BC, and that is of three components, adding up to a hiring over the in the next period of 7,000 individuals, 2,000 to support visitation in long-term care and assisted living, 3,000 healthcare support workers, and approximately 2,000 more to fill existing vacancies. Approximately 1,284 FTEs have been hired to support visitation, so that's the first category of 2,000. In addition, 5,085 participants have entered the HCAP, that's the Healthcare Assistant Program participant pool after clearing preliminary checks. And since the middle of November, in addition to that, another 1,500 expressions of interest have been submitted, and the interest in the program continues to be high. I should say that on December 11, 2020, 2,527 HCSWs were allocated across 349 Phase 1 sites, including 101 early adopter sites, and hiring is complete for the early adopter sites, with 92% of the seats being filled. All of that is a significant effort to support not just senior services now, but into the future. I'd also note that in addition to the work that has been done in long-term care, I would note that especially in the Lower Mainland, where a significant number of outbreaks have occurred, Vancouver Coastal Health and Fraser Health staff have worked in leadership positions at outbreak sites from the beginning of the pandemic, but in particular since November. This includes staff to support those sites. As you know, our long-term care system includes health authority owned and operated sites. That's about 3 out of every 10 publicly funded beds, and for-profit and not-for-profit public beds in other sites. That's the majority of beds, but certainly there's no distinguishment between the two. Currently, today, as of yesterday, I should say, for a snapshot, about 96 VCH staff were deployed to outbreak sites. In other words, they volunteered to support those sites, and 116 staff in Fraser Health have done the same. And I want to just express my appreciation to them, to the families, to the residents in long-term care in what has been a very, very challenging and difficult time. we know, and we've known from the beginning, and that's why from the beginning, with the single site order, the decision to provide PPE, even though contractually it's not required, when it was a requirement of our providers who are in the private facilities with public beds. They were included in the supply chain. All of the efforts at infection control, adding workers as discussed here, and other supports. Because we understand, since visitation has been limited from March and then changed in July, that is a primary place that communities where there's significant community outbreaks has an impact on healthcare workers who are going in and working in long-term care. You'll see when you review today's outbreak reports that more than 600 people have passed away in long-term care, and that shows the vulnerability of people in long-term care to COVID-19. In comparison, a much smaller number, I think it's less than 15, have passed away at assisted living sites, and only less than a handful have passed away at independent living sites, which tells you that vulnerability and the vulnerability that people face there and the very significant challenges. So we are appreciative of all the work that's being done. We understand from the beginning, and that's why we've taken so many efforts and steps over time to try and protect long-term care homes, and we'll continue to do that. Because we know that long-term care homes, to be successful, require people to go in and provide services directly to people, to provide those direct services to people in some of the most personal of ways, whether it's providing baths or helping people go to the washroom or helping people to eat and providing care and sustenance in many ways, social and others. And so the challenge for those workers is considerable, and the challenge of keeping long-term care safe is considerable, and I am very appreciative of the role that everybody's done and everybody in the system's done. And I want to reach out to family members who I've spoken to from the beginning of the pandemic, who are dealing with the circumstances that I know personally of being separated from loved ones often, and the anxiety that produces, particularly when a site where someone you love is involved in an outbreak site. It is a moment that nobody who's been in those circumstances will forget. And we think about that, we work on that every single day. Our work is not done, whether in our essential services like healthcare, transportation, food supply, pharmacy, or restaurants, or in our communities, workplaces, or households. Our work is not done. For each of us, no matter our calling, no matter where we live in BC, no matter all that we've done to stop the spread so far, our job always, our priority always, our focus always, and our duty still is to stop the spread, to use the skills we've learned, the guidance we've been given, the masks we are required to wear, or other PPE essential to our work that we use to stop the spread. We must each stay 100% all in our commitment to stop the spread. Right now, we must also stay committed to the tolerance, kindness, empathy, and forgiveness that have made our BC fight uniquely our own. I agree entirely with the comments made by Dr. Henry today with respect to racism. We must, at this time, do everything we can to stop that pandemic too. And we must qualities, the ones that we are so proud of to each other and to ourselves. In doing that, we'll make the future we've been working towards a better one. Now more than ever, and with more of us now than ever before, we must stop the spread. Aujourd'hui, nous annonçons 537 nouveaux cas qui ont testé positifs pour COVID-19 pour un total de 59 608 cas en Colombie-Britannique. Nous sommes attristés d'annoncer 7 nouveaux décès liés au COVID-19 pour un total de 1038 décès en Colombie-Britannique. Nous offrons nos condoléances à tous ceux qui ont perdu leurs proches durant cette pandémie. Parmi l'ensemble des cas confirmés de COVID-19, 362 personnes sont actuellement hospitalisées, dont 74 en soins intensifs. Merci beaucoup. Thank you very much. We're happy to take your questions.
Thank you, Minister. As a reminder to everybody on the phone, please press star 1 to enter the queue. You are limited to one question and one follow-up only. Please also take your phones off mute. You're not audible until I call your name. First question today is from Mary Griffin, Check News.
Oh, hi. Thanks so much for taking my question, Dr. Henry and Minister Dix. I'm just wondering if you have any reaction to the Premier musing today about seeking legal advice on prohibiting interprovincial travel into British Columbia.
Sure. This is something that has come up as an issue starting way back in March, and you will recall that we were one of the first provinces who was calling for border measures from international borders, and we still need to make sure that those are strengthened. We know there's been challenges, and we see that with the new variants that we've been following lately. It's also been a challenge to try and ensure that we have measures that support people here in BC. And early on, we talked about having parks available for BC only. And through the summer, that was our promotion, to stay local. And we do have requirements that people who come into British Columbia must follow the rules that are in place here. And that is something that is continuing to be reinforced. We, at my level, as well as I understand at the Premier's level, have been talking with our colleagues across the country about the need to try and stay put unless there's essential reasons for travel interprovincially as well. Those are important considerations. Right now, I do not feel I have the authority to do those types of actions, and we're looking at what types of actions may be needed. And is there other ways that we can ensure that people in British Columbia are protected from people coming from other places who might bring risk with them? Having said that, I know that there are many people who are still concerned about license plates and seeing people who have come from other places. And we must remember, as always, we don't always know everybody's story. And there are many people who have come here who have been here for months or weeks and who have the same risk that we have. And for all of us here in British Columbia, it's important for us to continue to stay local, to reduce our travel, to reduce our social interactions unless it's essential.
Do you have a follow-up, Mary?
I do. Thanks so much, Lindsay. I was just wondering, would you be in favor of quarantining? So if someone is coming here for non-essential reasons, they would have to go through a mandatory 2-week quarantine. And would you, right now it's a recommendation for non-essential travel, but is there a consideration to make that a public order, no essential travel?
We have not considered making that an order for a whole variety of reasons that we've talked through many times. There are many different interpretations of what essential travel is, and we have learned that we can trust people to make those choices for the most part, and we need to reinforce, and there's other ways of trying to reinforce what essential actually is for people. So no, I'm not considering doing a public health order around requirements around travel, either interprovincially or in BC. There are options, as we've seen in some of the communities in the Yukon, for example, and of course the Atlantic provinces, where a strict quarantine is maintained. In discussions with the many people that we make these decisions with, it's hard to see how that is feasible in British Columbia for many reasons. Our borders are very different. We have many ways that people can cross, particularly from Alberta, and we know that there are many services and workplaces that people live in one or the other province and move back and forth for reasons of work and other things, including medical services that people receive in different provinces. So it is a very challenging one for us. We don't have those simple borders. In my home province of Prince Edward Island, when there's only 2 ways to get in, it's much easier to be able to monitor that type of travel. So not as easy for us in British Columbia. Do you want to answer that?
I wanted to emphasize just first of all that it doesn't just apply to people coming from Alberta to British Columbia or coming from Ontario or Quebec to British Columbia, but this applies to British Columbians traveling there, that we have an obligation as well not to engage in non-essential travel to other provinces. This is a message I know health ministers in provinces are delivering everywhere, and I think it's an important message. There are a number of ways of looking at it. The Premier made it clear today that this is a serious issue for British Columbia. And we have taken action, for example, with what would be called essential travel around workplaces in terms of regulating that travel in the north. And there's been a public health order around that question about essential travel to see how closely and seriously we look at this question. There are some vacation spots in BC now that are chosen of their own accord to limit reservations at their sites in order to keep people safe and to stop non-essential travel, and essentially to make those sites local ski hills, for example. So there's a number of ways looking at it. The Premier has made that clear. It goes beyond the Ministry of Health or the provincial health officer to other ministries of government. But this is the time when vaccines are here to dig in and to stop the spread. Because in this period, that is the best way that we can all contribute to keeping people safe. Our most vulnerable people safe, and everyone else as well.
Next question is from Keith Baldry, Global News.
Oh, hi, thank you very much. Dr. Henry, I just want to go back to something the minister raised, was the interior number, the biggest case number, I think, since the pandemic began there. And that's where the biggest growth of active cases are. Fraser's declining, Vancouver Coastal is declining. Interior is now ahead of Vancouver Coastal in terms of numbers. To what do you attribute that? Is it improper gathering during the holiday season? It is 14 days since New Year's Eve.
Yeah, and that is certainly one of the big components that we're seeing in a number of communities across the interior. So it's not focused in one area. We saw that in the summer where there was a lot of focus on people holidaying. What we're seeing is more local, where people had come together in small groups, had decided that they could stretch those rules, and we're seeing transmission in small clusters that is moving through communities. And it's very challenging because it's not related to large events like we were seeing before. It's related to people thinking it's okay if it's just a few of us. And unfortunately, it is spreading in all communities now. We have seen some very severe outbreaks, certainly in a couple of First Nations communities, in Revelstoke, in Big White, of course, we know that is ongoing. So now in the interior, we are seeing the implications of what could happen in this province if we had all taken those liberties a few weeks ago. But it is absolutely reflective of people getting together over the holiday season, and that is now putting at risk our long-term care homes. It's putting schools in a more tenuous position. We can get through this. We can overcome that surge by people paying attention now and going back to not having those social gatherings, making sure you're staying with your household, monitoring yourself for symptoms, get tested, and stay away from others if you're feeling unwell.
Keith, do you have a follow-up?
No, I'm good. Thank you very much.
Thank you very much. Next question's from Marcella Bernardo, News 1130.
Hi, Dr. Henry and Minister Dix. I wanted to follow up on something that I asked about yesterday regarding long-term care, and specifically about the outbreak that was declared at Little Mountain Place on November 22nd, which was 2 days after a staff member tested positive for COVID-19 at that facility. So can you clarify whether or not anything has changed province-wide when it comes to declaring an outbreak in a healthcare facility or a care home? Because Vancouver Coastal Health has been telling family members that it doesn't rely now just on one case. It could be more than one case before an outbreak is declared. And from what I understand, what your directives have been for several months now, it's that if there's one case in a care home, whether it's a staff member or a resident, that qualifies as an outbreak.
Yes, so from a long time, and there has been no change. When we've had a single case in a resident, absolutely, that is an outbreak. If there's a single staff case and there does not appear to have been exposures in the facility, so the person wasn't in the facility when they were infectious to others or weren't wearing PPE, then it may not be declared an outbreak. It may be if we knew where the person was infected from and that there wasn't an exposure in the facility and that person was no longer in the facility, then it in some places it would be put on enhanced surveillance and monitoring and checking the residents and other staff members to see if there was anything else going on. So that has always been the way. There is some discretion about whether there was, from a staff perspective, whether there was any potential exposure within the facility. So I can't speak to that specific staff member and what the assessment was at the time, but there has been no change in that. We are thinking about how are we going to manage things now that we have people immunized and protected and what that means, but we have not yet changed. We have not made any changes to the policy.
Do you have a follow-up, Marcella?
I do, and it's still about Little Mountain Place. I spoke with Isabel McKenzie, BC Seniors Advocate, yesterday, and she still seems to be pushing for more testing in healthcare homes, even if it's just twice a week, so that something like what happened at Little Mountain Place doesn't happen again. If we knew that a staff member had tested positive November 20th and a resident didn't test positive until November 22nd, if everybody had been tested in between those 2 days, there's a chance we wouldn't have seen 41 people dying. So is it because there's not a lot of lab availability to test everybody, or what is the reason for not conducting more tests of healthcare workers?
Yeah, so I think there's a couple of things there. One is it takes time for tests to come back, and so that time frame of a day or two, the fact that testing was being initiated on staff and residents because of the indicator that they saw is the appropriate response that we would have. There is a lot of testing that is done, especially when there's any concerns in healthcare workers. And yes, I think it's much more feasible to think about having healthcare workers go to a testing site periodically to be tested, and that's something that we looked at in some detail. That's being done in Ontario still. It's being done, was done in Alberta for a short period of time. The challenge is that it's not, it's very low yield and it's challenging to do. The testing that was previously being proposed by a number of people, including the seniors representative, about doing rapid testing on site on a daily basis, I think is something that is just not feasible with the tests that we have. And our focus has been instead on making sure we have the resources to ensure staffing, particularly if an outbreak has been identified. When an outbreak is identified, testing is done, and it's the gold standard testing using PCR testing that's done in the home of all staff and all residents. So it is an iterative process. We are trying to learn from each of the facility outbreaks that we've had. We've been, my colleagues in public health and the outbreak response teams spend a lot of time trying to understand what is the best way that we can do. Testing is part of it, absolutely, and has been from the beginning, and we've been trying many different types of testing to see if it can make a difference. We have been, from the very beginning, doing everything we can think of to try and reduce the risk in care homes. And that will become very apparent. I know the seniors representative is going to be looking at Little Mountain in some more detail, which is always something that we welcome. And these are just very, very challenging outbreaks to manage.
Jane Side, North Shore News.
Hello. My question kind of carries on from what was being asked earlier about the interior, but I guess I'm wondering more in terms of the province as a whole, especially in Vancouver Coastal Health and Fraser. Where are the current cases coming from? Are those groups of a couple people getting together? Are they
workplaces? Are they gyms? Are they larger gatherings? What's behind the current cases?
Yeah, it's all of the above except gyms and we do monitor this quite carefully, and since we put in the additional restrictions in a number of places, we're not seeing transmission in those places. We very rarely see transmission in restaurants when the safety precautions are being followed appropriately in restaurants. What we have seen is absolutely workplaces, where we've seen quite large clusters in workplaces sometimes, and it's the workers. It's not the interaction with the public. It's the people having lunch together or in their break rooms or working in, we've had a couple of large outbreaks in more food processing plants, and some in light industrial, some of the packaging and shipping, whether it's Amazon or Canada Post, where people are working in warehouses, but they have their breaks together in a room where they're eating and talking together, or they're carpooling together. And then we know as well, particularly in the interior, it's been related to shared accommodations, young people. It's a higher proportion of younger people who are being infected and passing it on, and inadvertently passing it on through smaller groups to families and others. So it is one of those, again, where it's a whole variety of smaller settings now, with some larger workplace settings and some larger outbreaks in communities, but also related to, like we saw at Big White, for example.
Do you have a follow-up, Jane?
I do have another question. It's on the topic of vaccines. If you have received the vaccine, and presumably when it takes effect, you can't actually become infected with COVID, is it possible for you to transmit it even if you aren't yourself infected? That's a question that has come up, and I don't know the answer to it. I'm curious.
So a little bit of if you're not infected, you can't transmit it because you don't have the virus. But what we don't yet know is whether the vaccine prevents you from being infected. So being infected means the virus is in your body and you may not be showing symptoms. We do know that the vaccines that we have, the Pfizer and the Moderna vaccines, are very effective at preventing symptoms, especially severe symptoms, and preventing people from hospitalization and dying from COVID. What we don't yet know is if it prevents you from getting infected at all. So that's why right now it's still really important that everybody continues to wear masks, to clean their hands regularly, to take those measures that we know prevent transmission of droplets between people. We do know that people who are asymptomatic or who have very minimal symptoms, who don't recognize that they're infected, actually don't transmit as well as people who are in the first part of their illness. So that's one thing. There are some evidence from the Moderna vaccine. The way they did the clinical trials is they tested people before they got their second dose to see if there were people who had asymptomatic infection. And the difference between people who had the vaccine versus the placebo showed that it looked like it probably protects against infection, which means you wouldn't be able to pass it on to other people. But we still don't know that for sure, and the data is being collected. Those clinical trials are going on for 2 years. They're following people. And as well, now that the vaccine is being used in millions of people around the world, Israel is one of the first out of the gate, and it's almost like a nice little clinical trial in its own, or a test case where we can monitor people very easily. So we're looking at with the data that's coming out of the UK, that's coming out of Israel, that's coming out of Canada, the US, to get better ideas about that. We also don't know how long protection from the vaccine lasts, but from the studies that have been done, it's at least 3 to 4 months, which is good news. So all of those questions are still a little bit up in the air.
Next question is from Richard Sussman, Global News.
Dr. Henry, I'm just wondering if any more thought has been given on how to prioritize the waiting lists for the vaccination clinics, and whether there will be differentiation between those who work in hospital settings to give those last-minute vaccines that may expire to, i.e., will nurses or long-term care staff be prioritized over porters or other people who may not have face-to-face interaction with patients or high-risk individuals?
Yeah, so in terms of the vaccine clinics that we're running now, absolutely. The idea is, and I know all of the clinics are working on that to make sure that there are people at risk who are there to receive vaccine and to fill in if there's vacancies or end of the day. Having said that, everybody in a hospital right now is somebody that we want to be immunized to protect our health system. So, yes, when we have more vaccine, that's going to be a higher priority. And there are many stories that we've heard, that I have heard, about people who have made that extra effort to go out and find somebody who's in the high-risk category, whether it's an alternate level of care patient who's in the hospital or whether it's somebody who's working in the ICU who hasn't got their vaccine yet. So people are doing the right thing for the most part, and I think we need to celebrate that, the fact that we have not wasted vaccine and that we're getting it into those people most at risk.
Follow up, Richard?
How can British Columbians be guaranteed that when we move into mass vaccinations in April, that there will be precautions in place to ensure that the right people are getting the vaccine, especially if there are cancellations which are expected, and we may have like large groups of people all sort of coming on board at the same time in terms of priority?
Mm-hmm. Well, that's the work that Dr. Ballum is going to solve for us all by next week. We've been thinking about this quite a lot. How do we make it fair for people? The group that we're thinking about most urgently is we know that we want to provide vaccine to people over the age of 80 who live in the community, so who aren't in long-term care where we're focusing right now. How do we do that? How do we do that in a way that makes sure that everybody is contacted, knows where to go, doesn't have to stand for hours in the rain, as we've seen in some places, other places. So we are working on that. We have some great ideas that are coming together, and we'll be providing more data and more, not more data, but more absolute information about that next week.
We have time for one more question. For everyone listening, Dr. Henry and Minister Dix will release a statement this afternoon with the latest information on cases, hospitalizations, and outbreaks, which you can find at news.gov.bc.ca. For updated province-wide restrictions, visit gov.bc.ca/COVID restrictions. And for information about the province's new orders and pandemic supports, visit gov.bc.ca/COVID-19. Last question today is from Susie De Silva, CBC.
Thank you very much. You mentioned about the South African variant, that if contact tracing hasn't yet turned up a connection to travel for that person who has that variant, and I believe you went to say that you don't believe it has spread in the community, how can you be confident in saying that if you still don't know where it has come from?
Well, we don't know how that person got it yet, but I'm confident there's not spread from that person to others. So, yes, thanks for making that clear. It is a challenge. We don't know. I have some confidence, I have quite a bit of confidence from our lab and the testing that we're doing, that it's not widespread. We're not seeing lots of that variant showing up in the whole genome sequencing that we're doing, and we're trying to do it in a systematic way to test randomly in the community, to test more of the sequences from areas where we know there have been people who've traveled who've had the variant. So we are coming up with another strategy, a broader strategy, to see how we can even do better at that, looking at things like wastewater and other things. But right now, we don't believe that either of those variants are causing a lot of spread of illness in our communities yet, but we are not by any means out of the woods. So it may be that we're in a very similar place than we were in February of last year, where we have importations, and if we can find them and catch them early, we can prevent that variant from spreading. But it is, of course, a concern, and we're continuing to monitor.
Susie, do you have a follow-up?
Yeah, I know you just mentioned there about the challenges and looking at changing things. Can you give a sense in terms of how many of these types of tests are being done? Like what percentage of the cases that come back are actually being checked to see if they have the variants? And is this your biggest concern? And BC's been holding the line recently, especially in comparison with elsewhere, that this could be a game changer if it does begin to spread widely here?
Yeah, I think, we're in that bit of a race right now between how much vaccine we have and how much transmission in our community, and this is why it's so important. The one thing we know about these variants is they are still amenable. They still spread from person to person in the same way. And the things that we do to stop the spread work. So that's why we're so focused on the things that we need to do now. So that's really important. We have all along been doing sampling, either in outbreaks, in situations where we see unusual transmission patterns, and random samples of about 5% of all of our sequences, all of our genomes that are the isolates that we've had across the board since the very beginning, and that's about the same percentage as the UK was doing when they picked up their variant. So I'm fairly confident that if we were seeing a lot of spread from one of these new variants, we would have picked that up. But it does show us that we are connected. What happens in the UK comes here, and it's just a matter of time. Same with South Africa. So, and most recently today, there was some concern about another variant with some similar differences in the stock protein, the spike protein from Columbus, Ohio, and whether we're going to see that one here. So it is a challenging thing to look for those. We do a fair amount here. We've got a good program. We're doing it in collaboration with the National Microbiology Lab, and so we can have some confidence. Obviously, right now with the concern that we're seeing, we want to step that up, and we want to remind everybody of how important it is that we know what to do to stop the spread, and we need to keep doing it because an end is in sight, and we need to get there.
Oui, pour dire en français qu'il y a le Dr Henry a indiqué premièrement que cette variété, la personne, le cas, nous avons beaucoup de confiance qu'il n'y a pas de transmission de cette personne. Donc, on a été clair. C'est pas clair comment cette personne, le virus a été transmis à cette personne, mais il y a beaucoup de confiance que cette personne n'a pas transmis le virus ailleurs. Ces variétés de COVID-19, que ce soit celle dite Grande-Bretagne, celle du Royaume-Uni, celle dite sud-africaine, celle du Columbus, Ohio, donnent des nouveaux défis à notre système de santé. Mais force est de reconnaître le suivant, que tout ce qu'on fait pour réduire la transmission de COVID-19 en général, tout ce qu'on fait pour réduire cette transmission marche pour ces variétés aussi. Donc il faut surtout maintenant, surtout quand on commence notre campagne de vacciner tout le monde dans la province, il faut être à 100% là pour réduire la transmission, que ce soit de ces nouvelles variétés, bien entendu, ou le COVID-19 tout court. Donc, ça c'est important et c'est essentiel maintenant. Je pense que il n'y a pas d'évidence actuellement qu'il y a beaucoup de transmission de ces variétés ici en Colombie-Britannique, mais on est en garde, bien entendu. Merci, thank you. We'll see you on Monday.